So Dr. Wong has done a tremendous introduction to this subject, and I'm going to repeat a few things because I think repetition is probably a good thing. That's how we learn. And my perspectives of some of the issues may be a little bit different because I'm a pathologist. And as you know, pathologists are not usually involved in seeing patients primarily, but we are involved in making the diagnosis. I want to just start with the objectives of our talk. This is a standard CME thing, so for the medical folks in the crowd, you know that we need to start off by what it is we want to try and do. And I think from this talk, we hope that we'll clarify some definitions and terminology, make sure that you're familiar with the changing classifications and the reasons for that. Obviously recognize clinical features of carcinoid syndrome, understand rational use of tumor markers. That's going to be my job, just to tell you where they come from, and Dr. Izat's to tell you how we measure them. And then describe a little bit about functioning and functional imaging and therapeutic options. So I'm going to start with some definitions, histologic features, and molecular genetics, just so that everybody understands the biology of the disease. And then Dr. Izat's going to talk about clinical presentations, circulating markers confirming the diagnosis, and then what do we do with you once we know we have the diagnosis. So I'm going to start with some fundamental issues that I think everybody should understand. One of them is about terminology. The term carcinoid tumor is something that I think we as a community need to lobby against the use of. Because as Dr. Wong very nicely told you, historically, this is a term that was coined originally in 1907, and it's a misnomer. And I think it's been a source of major confusion in the medical community and certainly in the patient community as a result, because carcinoid means carcinoma-like. And for many, many years, pathologists have been making the diagnosis of carcinoid tumor, and the implication is it's benign, and patients have been told they have a benign tumor, and then they come back with metastatic disease down the road. Carcinoid is a German word. Obendorfer was a pathologist, so I take full responsibility for this. And what he described in 1907 was something in a tumor that looked like it could be a carcinoma. It had some of those features, but there was no clear-cut evidence of malignancy, so he called it carcinoma-like. Today we know that these tumors look like that all the time, and we know that a percentage of them are malignant. So the term should not be used as far as I'm concerned, and I think the movement towards the use of neuroendocrine tumor is a much better one. And as we move ahead with markers and basic biology and molecular markers, we will start to much better understand which have a likelihood of behaving in a more indolent fashion and therefore can be watched, and those which are going to behave in a more aggressive fashion, even if they don't look malignant at the time of diagnosis. That's very different from the terminology that we use for carcinoid syndrome. That's a well-established term in the literature. Everybody understands what carcinoid syndrome means. It's very clear, and I think as long as that term is embedded, obviously we're going to continue to use it. But the two do not mean the same thing, because as I will show you, not every neuroendocrine tumor is a carcinoid tumor in the sense that it makes the hormones that give rise to carcinoid syndrome. And not every carcinoid syndrome is associated with a neuroendocrine malignancy or benign tumor. I think these definitions, this confusion has to be clarified. The syndrome is almost always a malignant syndrome. So terminology is wrong, yes, we'll accept it for the syndrome, but let's be much more clear about diagnosis of what the lesion is, what's the basic process that's happening, what the prognosis means, and so on. Now, the other thing that I think we need to be more clear about is what do we mean by neuroendocrine tumors? This is a standard chart, and you've seen all the data that Dr. Wong presented, and I don't want to duplicate this list. What I do want to bring to the perspective of everybody in this room is, what are really neuroendocrine tumors all about? And as an endocrine pathologist looking at these tumors in the microscope, not in the patient, and understanding the biology of what they look like at the cellular level and the subcellular level, and what they do in the way of making hormones, this list is horribly incomplete. Because in fact, neuroendocrine cells occur in the pituitary. As Dr. Wong said, many thyroid cancers are neuroendocrine carcinomas, the medullary carcinomas. Parathyroid tumors are neuroendocrine tumors, and they sometimes are malignant as well. tumors in the bronchus, in the thymus, which is never on this list. I've seen patients who have thymic endocrine carcinomas. They behave exactly the same way clinically, depending on which hormone they make. Then, of course, the ones we know well throughout the lung, in the GI tract. Pancreas. Pancreas is on some people's list and not others. This list doesn't have it. Dr. Wong mentioned it. I mean, these are all part and parcel of the same phenomenon. And you already heard about ovary. We've seen patients who have primary tumors in their ovary, primary tumors in their cervix, in the testis, in the prostate. These tumors can occur anywhere. And the reason is that these little precursor cells, which may arise in a very specific part of the embryo, when we look at embryology, they migrate during gestation, when a baby is being formed. These precursor cells migrate throughout the body, and they park themselves in different tissues where their job is a regulatory job. If you think about your body, you've got a brain that extends processes out to give you nerves throughout your body, and we all understand how the brain controls the big toe through nerves. And the reason we understand that is that they're attached by cords, and that's the spinal column. Endocrine cells do the same thing, but they do it a little bit differently because they're not attached. They move and they spread themselves around and they talk to each other through blood. But it's the same fundamental principle. So we have to stand back and recognize that these are not GI tumors, they're not lung tumors. These are neuroendocrine tumors, and it's a very different phenomenon. And if we stand back and take a new perspective as we think about this, I think we will all do much better in the long run. And now, understanding that these tumors all are related, it's very easy for us to understand that their job is to make hormones. That's what endocrine cells do. They regulate the body by making hormones that they secrete into the bloodstream, and through the bloodstream, those hormones talk to their target cells and they regulate the functions of the body. And these tumors come in different places, and each place has its biologically programmed set of hormones that regulate the targets. Sometimes those targets are distant, sometimes they're right next door, sometimes the cells regulate each other living side by side, as in the pancreatic islets. But if we stand back and think about how they're all related, sometimes we will have a better understanding of how they can go wrong. Because we all know that sometimes a tumor in the pancreas or gut can make a patient develop Cushing's syndrome, which belongs in the pituitary. But we know that these cells are related, and so they can make each other's hormones. It's kind of like, do you recognize your daughter or your son because they look a little bit like you? Well, that happens in endocrine tumors as well. So sometimes we can get gastrinomas. Gastrin belongs in the stomach, but gastrinomas often occur in the pancreas. They're related. It makes sense. So all of this chart is about how do patients present, and the reality is that we've got really one tumor type that can occur anywhere in the body and can present with a number of different presentations. Anything from diarrhea and the classic features of the carcinoid syndrome, which happens to be one hormone out of about 200 that these tumors can make, to Cushing's syndrome. Now, the other thing is that you'll notice in most charts we have about 40% of these tumors that we call non-functioning. 100 years ago, they were all non-functioning. What does that mean? It means that we don't understand it. All of these tumors make hormones. They make something because all of the cells that they come from do that. We just don't recognize it, and over time we know that with all endocrine tumors, the more we learn, the more we understand what the hormone is that these cells are making. And this is true of every endocrine tumor in the body. Many years ago, the vast majority of endocrine tumors weren't even recognized as that because they were all non-functioning. As we've cloned and identified new hormones over time, we've started to create new syndromes. Now then, the last issue is how do we recognize which ones will be good and which ones will be bad? And again, this is an area where over time we're starting to identify new things that teach us lessons, but this is an area where we still have an awful lot of work to do. Now, you've already seen this slide in a different format. Dr. Wong already presented it. Mine is actually taken from the WHO book on endocrine tumors, which is the pancreas. I think the one you used was from the GI book, and there are some very subtle differences. And again, this comes back to what I was saying earlier, that there are all kinds of people working on this. There are lung folks working on it, there are GI folks working on it, there are endocrine people working on it, and everybody's coming up with different answers. And I would argue that we should all be working together and saying, let's have a unified approach to how we deal with these things. Because if we're all going to sit and argue about whether in the lung or the pancreas the MIB1 labeling index needs to be 2 or 3%, we're wasting our time. We really need to be looking for the real markers that are going to give us the right answer. So we have a number of different markers. We do understand the issues of invasion and metastasis. And when a patient presents with metastatic disease in the liver, which is sadly not an unfortunate circumstance, it's already too late. We know it's malignant. I think we need to be finding the markers that will let us identify those primary tumors while they're still in the lung or still in the pancreas or hiding in the gut somewhere, and be able to say this patient needs to be treated before they get their metastatic disease. Now, you also heard earlier that there's well-differentiated and poorly differentiated tumors. And the poorly differentiated tumors are really nasty tumors, and those are the ones that pathologists look at the biopsy and they usually call them small cell carcinomas. We know what these tumors are. They're bad. They rarely make hormones. They're very aggressive. They're very atypical. And those are really what we would like to prevent. We really would like to be able to get these tumors before they get to that stage. Now, as a pathologist, I told you I really look primarily at these cells in the microscope, whether it's a light microscope or an electron microscope, or sometimes crushed up in molecular tests. But what I do know when I look at them is that they are all made of cells that may look the same on a routine stain, but I can, through an electron microscope or using fancy tests, which we call immunohistochemistry, subclassify them not as foregut, midgut, and hindgut tumors, but even much more sophisticatedly into subcellular cell types. And these are funny words, like we actually call them by their letter name, A cells, B cells, or you may have heard alpha and beta, depending if you want to be Greek or American. G cells and Z cells, and there are all kinds of these neuroendocrine cells throughout the body. C cells live in the thyroid, so sometimes the cell type tells you where they're from. Sometimes they're all mixed up in one organ, so you're not sure whether they're from the pancreas or the small bowel, for example, where the same cells can live. Each of these cell types, we know, has specific genetic machinery to make certain hormones. And so usually a cell type makes a specific hormone and is associated with a specific syndrome. And I'm not going to go through all the details of this chart, but I want to just point out two. Gastrin, for example, is a cell type, the G cell, that lives in the stomach normally. And so you can get a gastrinoma with the Zollinger-Ellison syndrome for a patient who's got a gastric neuroendocrine tumor. But gastrin also can be made by pancreatic endocrine cells only in the fetus, in the embryonic state. And then as you mature, your pancreas cells are not supposed to make gastrin anymore. But when you get a tumor in the pancreas, those cells might start to make gastrin again. And so most Zollinger-Ellison syndromes actually come from pancreatic tumors. What an interesting story that is. And you can see why there's dilemmas when we separate out the GI neuroendocrine tumors from pancreas. They're all the same thing. The other one I want to point out is the serotonin. Serotonin is made normally in the lung and in the GI tract, where it performs very important functional activities. And we know that these tumors can give rise to the carcinoid syndrome, but unlike many of the other tumors, that when they start making their hormone, we find it in a circulating fashion early on. When it's in the GI tract, serotonin is broken down in the liver. And so patients who have small bowel tumors will not have symptoms of the carcinoid syndrome until that tumor spreads to a place where it can escape the liver. And that's when they start getting symptoms. But if you have a lung carcinoid tumor or lung neuroendocrine tumor making serotonin, you can get carcinoid syndrome before you have metastatic disease. Again, a very interesting thing that we all need to understand in terms of the biology of the cells, where they are, and how their local environment allows them to behave differently from their neighbors down the street. So, again, what does a pathologist have to do with all of this? Well, when a patient has a neuroendocrine tumor, it's usually biopsied and it may go on to be resected. And when it gets resected, this is what it can look like. This is actually a piece of bowel, and you can see that in this bowel there's a little tiny polyp here, which is actually the tumor. Now, this tumor would be really hard to see while it's still in the patient. You can imagine how hard it is for you to see it when I'm showing it to you on this nice piece of tissue that's been opened up for you to examine. So you can understand why these tumors can get away hiding in the small bowel for so long. Now, one of the things that Dr. Wong mentioned earlier is that the incidence of these tumors is going up. And the reason for that is probably very heavily due to diagnosis. And again, this is something I will take responsibility for as a pathologist, especially in Canada today. You know how controversial pathology has been in the last year. Pathologists are not all experts at everything that they do, and pathologists don't always have all the tools available to them, as we know from the story in Newfoundland last year. So the diagnosis has to be made with a combination of different parameters, first and foremost being the pathologist's awareness of the possibility of a diagnosis to ask the question, and then having the right tools to be able to answer that question. So many years ago, tumors like the one I just showed you in the small bowel would have been called a small bowel tumor, a polyp. If the pathologist didn't think about the possibility of this being a neuroendocrine tumor, it may never have been diagnosed as such until the patient presented with metastatic disease in the liver and carcinoid syndrome. If they didn't, the diagnosis was missed. So those patients were lucky, but the numbers are wrong. So today we now have the questions that we ask about, is this an endocrine tumor? Where is the primary site? Is it benign or malignant? This is what that tumor can look like if you cut a section of it, stain it, and put it in a microscope. And this is a routine stain. And this is the classic appearance of a neuroendocrine tumor. You can see that for the medical folks in the audience, this is actually the mucosa. This is the lining of the small bowel. It's still quite intact. And even though these tumors actually start in, single cells that live in that lining, they tend to grow down and form these little nubbins of tumor that don't particularly look invasive and don't particularly look terribly nasty or malignant. And most of the time, we think that they live inside the lining, the outside lining of the small bowel, which is why they don't spread. But for those of you who have good eyes, and for the good pathologists in the crowd, you'll see that there are actually a few cells which, oops, sorry, now I can't get that pointer to work. There it is. You see these few cells just hiding down here? Now, if a biopsy was taken of this, there would be no way for a pathologist to know that those few cells escape through the muscle and into the outer lining of the wall. And that's why it's very hard to know what the diagnosis is. Is this benign or malignant? But if you've got a whole mount section like this from a surgical resection, you know that this is a bad tumor that has already escaped. Here's what it looks like on higher magnification. And as I said, it's really fascinating for us that these tumors actually arise up in these normal elements up here. One little cell can get a hit, a genetic hit, to start to become a tumor, start to form these nests of neuroendocrine cells that are abnormal, that are already transformed. But we know that if we catch these at an early stage, we're very likely to be able to cure them. As they proliferate, they start to grow down, they start to form larger nests, and they often start to dedifferentiate and become more aggressive. Now, I said we need the right tools to be able to confirm this diagnosis. When a pathologist has a high index of suspicion for neuroendocrine tumor as opposed to a non-neuroendocrine tumor, there are a number of very specific markers we can use to prove that. Neuron-specific enolase is one, not a very good one. It was an early one, but it's lousy actually. Most of us now use synaptophysin, and chromogranin, which is a very nice and very specific marker of neuroendocrine differentiation, and which happens to also offer us an excellent tool for a circulating marker of these tumors. Because if a tumor is making chromogranin A, we can use that to measure the circulating blood and follow the patients very carefully. The other problem that we often face is if we're diagnosing a metastatic tumor, which is unfortunately a common scenario of a patient who has a liver mass, they get a biopsy, the pathologist says this is a neuroendocrine tumor, the first question that's asked is, well, where is it coming from? These tumors very rarely arise primarily in the liver. They usually spread there. But they can spread there from the small bowel, the pancreas, and the lung. So how's the pathologist to help the clinician figure out where they need to go looking next? And again, as time goes by, we have developed more and more specific markers of what we call transcription factors that are unique to specific parts of the body. So for example, if a tumor has TTF in it, it's very likely to be coming from the thyroid or the lung, whereas if it has CDX2, it's more likely to be coming from the small bowel. And so pathologists are becoming armed with many more tools that are helping us to do a better job of making the right diagnosis. Here are some examples of what these stains look like. Here's a neuroendocrine tumor, and you can see this tumor actually this happens to be in small bowel, and here's a very nice marker, and it doesn't matter what the marker is actually, whether it's synaptophysin or chromogranin, you all can see that it's really brown, and that's what the pathologists are looking for. We're looking for brown staining. The next step is, what about functional markers? And this is where I come back to my comment about non-functioning tumors. For the pathologist, far less than 40% of these tumors are really non-functioning. We often, if we look hard enough, will find some hormone in there. And then we can go to the clinicians and say, well, did this patient have a little bit of this or that? And if you go back and ask the questions, the symptoms were there. But people were not looking for them. They weren't asking the right questions. So again, I want to really emphasize that one of the slides Dr. Wong showed, again, struck very true to my concerns. Look at that long time lag that we see in making the right diagnosis for patients. The reason is that we are not thinking about it. We're not asking the right questions. We're not being suspicious enough. And again, this is a phenomenon that is true of neuroendocrine tumors everywhere in the body. And I'll give another example for the physicians in the crowd. When we went to medical school, we were taught that acromegaly is when you've got this horrible person who looks really giant and has this thick forehead, all the terrible features that we see in very delayed, very bad acromegaly. Today, acromegaly should be diagnosed on a group of patients who come in with insulin resistance. It should be something we think about. And this is the same story for neuroendocrine tumors everywhere in the body. The features may be subtle, but we should be more aware of them. And as a pathologist, I can confirm that subtlety by using all of these wonderful, beautiful markers that will tell me what the tumor is, what it's making, why the patient has a certain symptom. But I'm going to lay down the gauntlet now and say that I don't want to be doing that in 5 years from now. I want you guys already to know what the symptoms are and where this tumor is coming from all the things we're going to hear about later on today in terms of imaging and clinical diagnosis, which can get better using biochemical tests before we have to stick a needle into a patient and pull out a piece of tissue. What I want to do with that little tiny piece of tissue is use it much more wisely to identify receptors that are shown in some of these immunostains and identify molecular markers that are going to be the targets of very specific therapies that we will be inventing to prevent these tumors from growing and spreading. Now, Dr. Wong did ask me to talk about the Ki-67 index, and I will. The difficulty as a pathologist when looking at a little piece of tissue of a tumor biopsy is to say, is this really benign or malignant? And the traditional ways that pathologists do that is by looking at cytology, cytologic features. And you know, in many parts of the body, like even in the cervix when we do cervical screening on pap smears, we can look at a nucleus and we can tell whether a cell is atypical, does it have an HPV infection, is it benign, is it borderline, or is it malignant, or is it invasive? In endocrine tissues, we can't do that. Some of the worst atypia that I have seen in endocrine tissues is in secondary hyperplasias. And I'll give you an example. Patients who have renal failure develop secondary hyperparathyroidism, and we often take out those parathyroids to cure them. And they look awful. And by most conventional pathologist criteria, we would want to call those malignant, and we know they aren't at all. And that's true of endocrine tissues throughout the body. So some of these tumors can look really benign using conventional histopathology, and yet they metastasize. Many years ago, we looked at ploidy as a marker. And now we're using Ki-67. So we do a stain, we find a positive cell, we say this cell is ready to mitose, it's dividing. So this is an aggressive tumor. The more dividing cells we have, the more aggressive this tumor will be. And yes, that is state of the art today, and we do have criteria, and 2%, 5%, 10% of dividing cells. This is a very crude measure of a very late event. And I don't like it. I use it, I have to, and I agree that we need it in the current guidelines, but I sure hope it goes away because I want to have better markers for this that are going to predict much earlier on what's going to behave. We do have some other markers that are starting to be identified through pathologist studies, things like cytokeratin 19, CCAM1, E-cadherin. These are markers that a pathologist can do one of those brown and white stains on and say this neuroendocrine tumor is very likely to metastasize and that one is less likely to metastasize. And that's great. But we can't stop now. We have to keep going. And this is actually Dr. Izat's favorite slide, and I'm not going to tell you all about the gory details that are on it because it would take me about the whole day, or maybe more. And I didn't let him use the slide because he would try and do that for you. This is a slide of a cell with what we call signaling pathways. And it's very complex because cells are very, very complex. And they have all kinds of proteins in them that I can stain for using immunohistochemistry. And each of these proteins plays an important role in regulating how a cell functions. Does it make a hormone or not? Does it make a lot of hormone or is it being a bit lazy? Is it starting to think about dividing, or is it dividing, or is it starting to lose its attachment to its native environment so it can get away into the bloodstream and spread and do something nasty in the way of metastatic disease? There are very complex signaling pathways in every cell in our body. And one of the jobs that we do in our research lab, and many other people throughout the world are doing in their research labs, is they're pulling out individual proteins that are coming out of array studies that we do. And each of these proteins we're looking at by putting them, we have wonderful tools available to us today. We can take a protein expression vector and put it into a cell and play with that cell in the laboratory and watch whether it grows faster or slower. We can inject that cell into a mouse and see if that cell will spread or will it stay where we inject it. We can then make mice that are genetically engineered to overexpress that gene in their cells. And we can target that expression to neuroendocrine cells and see, do they get hormone tumors? Do they get silent tumors? Do they get tumors that stay in one place, or do those tumors spread? And really, that is where I think we all need to be working today to try and better understand what causes these tumors. How do they behave? Can we predict how they will behave? Can we target the bad genes that are out of line to stop them from doing what they do? And we have a little bit of light on the horizon. So I'm just going to give you a few slides of what we do know, and I really hope that I've inspired you that this is where we should be going. So what about things that we do know? Well, we know that patients who have multiple endocrine neoplasia type 1 get neuroendocrine tumors. And again, I want to remind you, where are those tumors? They're in the pituitary, the parathyroid. Yeah, those weren't neuroendocrine tumors initially, right? The pancreas, the GI tract, the thymus. Wow, they're all tied together, aren't they? And we know what the gene is. They have a menin mutation. They have a mutation in their MEN1 gene. And what happens is they have one bad copy, but as long as you got one good one, you're fine. And then something happens during their life that hits that second copy in their pituitaries, in their parathyroids, in their thymus, in their GI tract, wherever it is. That's what we call loss of heterozygosity. They lose the good housekeeper, and only the bad one is left behind, and it can't do its job, so they get tumors. Knowing that patients who have this, have MEN1, get these tumors, we all thought, oh, well, that's great. That gene was cloned in 1997, and we all ran out and looked at sporadic tumors from patients who are not in families with multiple endocrine neoplasia type 1, and we said, oh, well, that gene is going to be the implicated target in all of these sporadic tumors. Well, guess what? It's not. It is in some of them, but it's not in enough of them for us to really implicate this as the cause of these tumors. P53 is another very important tumor suppressor gene, which is mutated in a lot of sporadic cancers like colon and lung. Again, not in neuroendocrine tumors. We know from doing some very nice gene studies that there are specific chromosomal targets that are lost in neuroendocrine tumors. Chromosome 3P, 5Q, that whole list at the bottom. But we don't know what are the important genes that are in those specific areas of the chromosomes that are lost that matter, because every tumor has loss of chromosomal material, but it may not matter if it doesn't have a gene of interest on it. So the other question that we ask is, can these genetic alterations help us to tell where the tumor is coming from? And we know that metastatic tumors have different genetic losses than their primaries do. And we know that primary lung tumors may have different losses than primary tumors in the gastroenteropancreatic tract. So all of this is known information, but how do we apply it to better diagnosis is the real question. The other thing that we need to be thinking apart from just the chromosomal losses is, remember what I said about Ki67? That's a marker of whether cells are proliferating or not. Well, we need to be able to understand why Ki67 is being turned on in some tumors and not others. And this is actually a picture of what we call the cell cycle. All cells in the body normally live in a rest phase. And then when something happens that they need to grow because either something's been damaged or they're not doing their job well enough, so we try and make babies that will do a better job, that cell cycle gets activated and the cell starts to duplicate itself. And you end up with 2 cells and then 4 cells and so on. So the regulators that determine whether a cell is growing or not are kind of like the brakes and the gas of the car. And so there are what we call oncogenes that are the gas, and there are tumor suppressor genes, which are the brakes that turn off that process. And we know that in a lot of tumors, the brakes, the cyclin-dependent kinases and their inhibitors and all of these various important molecules are what are implicated in allowing cells to grow too fast. So retinoblastoma is one of the important brakes. P27 is an important brake mechanism for cells. And many of these are lost or downregulated in endocrine tumors. And so we know, for example, in gastroenteropancreatic tumors, there's an upregulation of one of the gas pedals, cyclin D1, and there's downregulation of one of the brakes, the cyclin D1 kinase inhibitor, P16. So are these potential targets that I've challenged us to find that we can use for the future to better treat patients? So I'm going to leave at that point with a lot of questions that I've asked for you to think about. And I'm going to let Dr. Izat come and show you how we apply all of the things that we do know for diagnosis, starting with an example of a case. Thank you.
Thank you very much, Sylvia, and for Dr. Wong for a wonderful introduction. So I have a bit of a daunting task. My training is in cancer and in hormones. And sometimes I have to deal with oncologists, and they always sort of think of me as being the hormone guy. So I'm going to start off by telling you that hormones are a distraction. They're probably the reason why there has been very little progress in this area for the last 100 years. Maureen said something which is very important. We're learning. And I'm going to spend a little bit of time in wisely trying to tell you what I've learned in the last 20 years as somebody who researches cancer and hormones. Rare and rarely diagnosed are 2 very different things. As Dr. Wong showed you, there's an increase in number of diagnoses. That does not mean that there are more patients who are developing the disease. It means there are more patients being diagnosed, relatively speaking. In all areas of medicine, generally, progress is made in the areas where the largest number of patients are making the most vocal demands. Breast and prostate have evolved significantly, so everybody knows what PSA and CA125 are. Biomarkers. The buzzword now is signatures, molecular signatures. What do I mean by that? Signatures are the hallmark by which different genes coming together, isolated from some part of the body, will tell you something about this disease. So that picture of what looked like Mars with all these elements in there that Dr. Asa showed you is a big bowl that contains all of the letters that hopefully can come together to create the possible combinations of signatures. So I'm going to challenge some of the oncologists in this country and probably in North America and say that if we're going to make progress in this area, the first thing we need to do is do what Dr. Wong did earlier today, is probably press delete, and let's start with a new program here. Because what we've done is we've built on very, very confined, restricted thinking that you've heard about with the term carcinoid. Huge flushing, wheezing, and diarrhea. Wait until you get those, then we're going to diagnose your disease, and then we're going to know what's wrong with you. And I would challenge that we have to wait for 9 months for a woman not to have a pregnancy and wait for her to become dilated, come into the hospital to diagnose pregnancy. It's a very effective way, and it's 100% sensitive and specific, but not terribly smart. So I suggest press delete. Start all over again. What we have in the body, and what Dr. Asa was really telling you about, is there are two big tubes in the body. The respiratory tract and the GI tract. And they have cells in them. And by and large, the two most common types of cells that you're going to find, I make it very simple for my students, those that don't make hormones and those that do. The ones that don't make hormones make mucus. So if a cancer starts from an unhormone-producing cell, that's what we call an adenocarcinoma. You've heard about it all the time in breast and prostate, every part of the body, adenocarcinoma. Now, if a cancer starts from a hormone-producing cell, and it can be anywhere in the body, it's not an adenocarcinoma anymore, it's an endocrine carcinoma. So I tell my students, it's very simple. Let's start from the beginning. Adenoendocrine. Now, you may think that it should be very simple because any pathologist, any radiologist should be able to look at that patient and say, you've got adeno or you've got endocrine. But the way that medicine is usually practiced is it's easy to be lazy because if it's common, that's what you've got. So if you present to the emergency room, as Dr. Wong mentioned, because of a car accident, and somebody does a CT scan or ultrasound of your belly and find that your liver is studded with cancer, you've got adenocarcinoma, because that's what we usually see all the time, adeno. But rarely a pathologist is actually going to take that step of looking at those cells and saying, you know what, they don't quite look right to me. Let me see if I can find a signature to tell me that this cell actually has a hormonal origin. We've moved completely now from endocrine or into the endocrine field away from the adeno. Why am I spending time on this? I am extremely worried, especially in this country. Not just about patients like yourself, and I think one strategy is going to be to actually go out there in the larger cancer community and wonder how many of them really belong here. How many of the treatment failures, how many of the pancreatic cancers, the colon cancers, and other types of cancers were diagnosed, treated, and sacrificed as adenos when they are really endocrines? Tremendous difference and changes, rare and rarely diagnosed. So let me go through this case here and illustrate some of the findings that make life sometimes frustrating but sometimes gratifying also. One of the things that has happened in the last 10 years is that we stopped using those damn hormones. Female hormones, right? Because you all know HRT is no longer a buzzword. We don't give estrogen to women anymore because it can cause breast cancer. So what has happened now is we have an epidemic of flushing. There are a lot more women in North America that flush because before we gave hormones all the time, they weren't flushing. Now everybody's flushing. And that's a problem. You all know about it, right? So it's an issue. And one of the things that I spend an awful lot of time with my medical students is to be able to tell the difference between menopausal flushing versus non-menopausal flushing. You may think it's actually very simple. But really, unless you think critically about it, it's very, very difficult. Because otherwise, a lot of cases that really were thought of as being, oh, you've just got menopause, don't worry about it. But wait a second, I am not having the classical features. Now, depending on how sophisticated and how diligent a patient is, and whether they go on the internet and find Maureen and maybe she'll tell them that actually this is not menopause. You've got a little bit more than that. Maybe, just like this woman, she's going to be, in fact, smart enough to get some more testing because she doesn't just have flushing. It's all over her body. She's got diarrhea. She's got other features. And lo and behold, she also gets a scan and a tumor in the gut is identified. So what we talk about is really the issue of symptoms. Where, when, and how. Do we really need to wait until somebody is flushed? Because remember, by the time you're flushed, it means you've got so much hormones. And that gets me back to, again, we have to think about the origin of it all. The problem we have is that cells can do one of two things. When they're alive, they can either grow, or if they happen to have the capacity to make hormones, they will secrete the hormone. And sometimes they can do both, but we can't always assume that the two are happening in a linear fashion. In other words, they're not always happening at the same time. In other words, you can have a very small tumor that's producing lots of hormones. Sometimes it's actually very difficult to find it. Or you can have a tumor that's growing very, very fast and not terribly efficient in making hormones. And that's my second most important message to you today, is that there isn't always a linear relationship between the two. So as a result, you can have somebody who's got a cancer, as Dr. Wong mentioned earlier, who's going to have small bowel obstruction, who's going to have obstructive symptoms, wherever they may be, whether it's in the lung or in the pancreas or in the gut, but also have potentially hormonal symptoms as well. And sometimes the two are very, very intermingled, and they can occur at different stages of the disease. Very, very important to understand this. So the reason why this is important is because this is a reflection not of how well we've done, it's actually a reflection of how poorly we've done. We've waited until the woman was maybe 8 months without a period. We've waited until the patients have had flushing, wheezing, diarrhea, and heart disease, valvular heart disease. That tells me this patient has been exposed to disease for years. And it's a problem, because obviously by then you've got metastatic disease. This is not going to be a patient who's going to be cured. Now, the classical thinking has been, oh, but it's cancer-like, don't worry about it. You're going to live for 10, 15 years. It's not a real cancer. I'm going to spend more of my effort looking after the real cancer patients. That's not really true. And it's honestly a lie. Because what we're talking about, just like we talk in breast and prostate, we've got low disease, low stage, we've got intermediate, we've got aggressive. This is exactly the same thing. It's not any different. So the first word that I will put in my new program after we press delete is what's similar, what's the same, rather than try and distinguish this disease so very differently from everything else. It's not. The only thing that has put it way out in left field is because of its capacity to make hormones. And in the back of the minds of the pathologists, as well as many of the oncologists for many years, is they've got to be very, very different. But the truth of the matter is they're not. They're cancers, and they exhibit the entire spectrum of behavior. And just because they happen to also have the capacity to make hormones does not make them that different or less important. So this is a struggle that I always have in communicating with not just other physicians, but sometimes also the patients, because they've been seeing somebody else who's told them, don't worry about it. I'm sure some of you have heard this. You've got a carcinoid tumor. You're going to be perfectly fine. You just don't really need to worry about it. Well, many of you know that also sometimes you get to a point where you've got secretory type of diarrhea, okay? Again, this is the 8-month-old pregnant woman. Don't like it very much because you've got bad disease here, and you've got diarrhea that persists in the absence of eating, meaning that the gut is working overtime as producing fluids that are just going through, and this is what we refer to as secretory diarrhea as compared to malabsorptive diarrhea. The diarrhea that occurs even if you don't eat, wakes you up at night, and obviously that's not very good. It can also occur, as has been pointed out earlier, because the gut is contracting more quickly, sometimes also as a result of obstruction, sometimes also of blood vessels impairing flow to the gut itself. Very rarely, this can also be the result of the hormonal influence, not just the serotonin, but also, and this is one of the types of cancers that I really hate seeing, when a patient has been having diarrhea for a long, long time, and what they have is medullary thyroid cancer. It's a type of cancer that's also neuroendocrine, starts from the neck, and I see the patient by the time that they have disease in the liver. And what's worse is sometimes it's heritable, and other family members happen to have the same thing. Not a very good situation. 8-month-old pregnancy again. Not good. Gastrinomas. This is a really big issue here. Zollinger-Ellison. I don't know if anybody here has this, but this is a type of tumor that's associated from the gastrin producing. Gastrin is a hormone that produces an excess of acid and causes ulcers, and causes typically the ulcers to keep coming back over and over again. Now, something that's happened within the last 5 or 10 years, we have what are called PPIs, proton pump inhibitors. And they've been a double-edged sword because they've been very, very potent at taking care of the ulcers. But they've also been very, very potent at covering up the disease. Why? Because when the patients take these drugs, you can't measure gastrin anymore. The gastrin is through the roof in any individual. So a lot of patients end up having their disease masked by these drugs, which are very effective, and for the most of the population, they're very good drugs. But if you happen to have a gastrinoma, PPIs have covered up your disease for a long time before ultimately somebody will do a scan and find that there is a growth there, usually arising from the duodenum, the first part of a bowel, and often these will go into the liver, and again, it's not curable disease. What I'm trying to explain to you is why there's been a sort of a shift in diagnoses. And, you know, if you think about it, most people out there demand a PSA. If you're a male, you want your PSA, regardless. Or if you're female, many want CA-125. Does that mean that I'm suggesting that everybody here should be asking for their chromogranin? The answer clearly is not. I think it's a question of how do we intelligently really apply this information, and that's hopefully what's going to be up for discussion. This has been pointed out earlier, and medical students, I think, represent a rate-limiting step, because if we don't do a better job at educating medical students, we're just going to get more and more of physicians that are thinking just like in 1887. Wait until you've got somebody who's got severe, what's referred to as rhinophyma, which is basically enlargement of the nose because their blood vessels are constantly being open and closed, and I've seen many of these patients actually being accused of being alcoholics when they tell you they've never touched any alcohol, right? I'm sure you've heard about this. This is end-stage disease. This is not an 8-month pregnancy. This is a 10-month pregnancy. And I want to show this, and I do in medical schools across the country, to show failure of what happens when you miss a diagnosis for a long time. It's not meant to be an example of what you should be looking for. Okay? It's a slightly different way of thinking. Rare, rarely diagnosed. Very different way. Flushing. We talked about this as being, and I'm sure many of you are aware, you know, the fact that it can be very irritating. This is not just the type of flushing that occurs with menopause. Usually there's no sweating that's associated with it. It's all over. It's all the time. It's throughout the body, which is unlike the typical upper part of the body that you see with menopause. Again, I want the average family physician to be able to recognize the difference. Why? Because remember, we don't have any female hormones, no AHRT anymore. Drugs are a bit of a problem, as I mentioned earlier. We see drugs as potentially affecting the nature of a disease, as I mentioned with hormones, in terms of various drugs that are sometimes used to treat a variety of conditions like alcoholism, even cholesterol. Some drugs that are used for hypertension cause some effect on flushing, and in fact can cause edema as well and can sort of cloud the issue. Very important to appreciate this difference. Heart disease, and Dr. Wong sort of mentioned this a little bit earlier. Many of you may actually even remember this, but many years ago there were drugs that were proposed for the treatment of obesity. And those drugs actually were removed from the market because of their association with valvular heart disease. Same mechanism, where they cause essentially scarring. So here we're talking about the situation where the cancer produces serotonin, serotonin in excess, especially when it's not inactivated properly by the liver, affects the collagen within the valves of the heart and causes these deposits that really become extremely problematic, and essentially it contributes to heart failure. And it's a type of heart disease that can't be readily treated in a classical way that you treat heart failure. I do want to emphasize, however, that there are probably many other substances that contribute to this that we have yet to learn about, and that it's not just a matter of serotonin and bradykinins. There may be other hormones that these cancers produce that we don't even measure. So it's important to appreciate this. And I can tell you, I've seen patients with other types of neuroendocrine tumors who've had valvular heart disease, and they did not have bradykinin excess or serotonin excess. So we have to be a little bit more aware of these possibilities. We don't do a very good job in Canada, to be honest with you, with detecting the heart disease, and I think it's something that we need to look at a little bit more carefully. It's not just a matter of an electrocardiogram, but an echocardiogram is something that should be done on a more regular basis, and with greater sensitivity, hopefully we can pick up these type of problems. Now, circulating markers, which is a form of molecular signature. It's an old style of signature. It's the way of looking at something that's being produced either in the blood or in the in urine as it's being excreted. Now, in this instance, we're using the hormone to track down the activity of the cell. But really, if you think about it, what we're changing is, in fact, applying a little bit of what's being done for non-endocrine cancers. There is, in fact, a move now not just to look at substances that are being secreted by the cancer cells, but actually looking for evidence of the cancer cells themselves in the circulation. We haven't quite moved to that yet in neuroendocrine tumors. Why? Because remember, we're down on the list. Okay, we're not high on the list, but it's going to come up there. I'm just giving you an idea of where we need to be heading. Because by the time we're looking for elevated urinary 5-HIA, we're kind of 7.5 months pregnant. Okay? Not very good. Sometimes we try and measure serotonin in the blood. The problem with that is depending on how it's collected, the platelets can actually secrete the serotonin, can give you a false elevation. Sometimes, however, that is used and sometimes it's necessary. So 5-HIA is sort of a relatively crude marker. When it is elevated under appropriate conditions, it's worthwhile. But remember, it's not a very good, sensitive, early test for disease. It's useful if you're trying to look at hormonal activity that's contributing to flushing, but I don't want it to be recognized and considered to be the be-all, end-all of A, diagnosing the disease, and B, how well it's being managed. Gastrin, as I mentioned, is a bit of a problem because of proton pump inhibitors. Losec, Prevacid, all these drugs that many of you may be familiar with their names. Vasoactive intestinal peptide, VIP, you would think with a name like that, that should be available in every lab in North America. Guess what? 2 labs. 2 labs in North America, and they're south of the border. We don't even do it here. But it's a very, very important test. Just last week, I got a phone call from Northern Ontario. Patient presented to a GI specialist. He said, this woman has been having diarrhea like crazy. What should I do? Should I get a chromogranin A? I said, please do me a favor. FedEx her blood sample to a lab in California. She's probably got a VIPoma. And sure enough, that's what she had. You know, they paid the few $100s to get the sample done. Quest Lab runs it, and you get an answer fairly quickly. Very, very important because those patients, and I don't know if there's anybody in the audience, but it's a very critical diagnosis to make because it is really very, very crucial in terms of early intervention. Pancreatic polypeptide is relatively easy. We measure it in just about every lab in Canada. It's a hormone that is relatively ubiquitous, meaning if you have a pancreatic neuroendocrine tumor, you will have pancreatic polypeptide. However, it's important that it be obtained under the right conditions, meaning that if a patient did not fast appropriately, it will be falsely elevated. If they're also taking a drug that's inhibiting secretion, as somatostatin analog, then it's not useful for the diagnosis because it will be inhibited. Many of you may be aware of that 5-HI is actually a breakdown product of serotonin. And this is just to give you a bit of a numbers game here. Most of the labs generally will want to see a value of less than 50. However, some bowel diseases can be associated with mild degree of elevation in 5-HIA. Typically, when you have carcinoid syndrome and you haven't had your period for 9 months, and if you're a female, that's the kind of carcinoid syndrome. So that's what we really like. That's the classical textbook teaching. Relatively late, don't like to see that. That's usually not very good. Many of you know that when you go and submit your urine sample, the lab insists that you follow a diet. Why? It's very important because if you're not consistent, what you're going to be measuring are really fluctuations in the way that your body is breaking down various foods that are causing the elevation. Okay, so foods like avocados, pineapples, and others, as well as drugs, will cause false elevations. And there are also drugs that you can take which will cause falsely low values, like if you've been drinking too much, or some of the phenothiazines that are used for patients with neuropsychiatric disorders, even aspirin or INH, which is used for TB, or even those who happen to be on heparin will have false reduction. Heparin is being used, obviously, if you happen to have a clotting disorder, and clotting does occur more commonly in patients with neuroendocrine tumors. So you've got to be aware that there are limitations. So these are not the be-all, end-alls. Okay? They're good pregnancy tests, but just like the ones you buy from Shoppers Drug Mart, they're not 100%, and you've got to be very critical in how you're applying them. I hope I'm not ruffling too many feathers, and in fact what I'm trying to do is actually sort of challenge you in terms of the way that we're thinking so we can actually move forward, and I really don't want to see things continue in the manner that they have before. I already mentioned about blood serotonin. Chromogranin A, and I'm going to be ending soon because I can see Maureen is trying to tell me that I'm not running over time, right? Okay. So chromogranin A, I just want to mention that there are relatively few labs in Canada that are actually measuring this. Chromogranin A is a substance that is produced from any hormone-producing cell in the body that has a secretory capacity. In fact, the most common in most of us here as we age is actually coming from our pituitary. As we go through menopause or andropause, this is an equal opportunity disease, we all will secrete chromogranin. Okay, so it's very important to appreciate this. So if you see a female or a male who's in that right age category, so chromogranin A doesn't tell you that you've got disease. It just gives you an idea of hormonal activity. And it's very, very important to appreciate this because it will give you an idea, potentially, if it's very, very elevated or in the right clinical context. So it's a useful test. And I really believe that it should be widely available, but just like any other test, it must be used intelligently. Otherwise, it is going to miss diagnoses or overcall diagnoses. I'll be happy to obviously elaborate on this. And I know I'm going to pause at this point, but hopefully what I've tried to do is try and get to think away and move away from the paradigm of the classical, these are really very, very unusual disorders, to disorders that happen to be cancers exhibiting the wide spectrum of behavior that, in addition, happen to have the capacity to also producing hormones. And it's not just about hormones. Thank you very much for your attention.
Actually, you're not that far. We're not that far over. It's just Maureen's staring at you. So just before the break, Jim would like to give just a few announcements, and then we'll reconvene at 10:40 for the next talk. Thank you.